Once you get a transplant, you're cured for life. Is that true?
Well, it's true because, well, again, it's one of those things that need a bit of definition.
What is the most critical moment during a transplant surgery?
Heart and lung transplant is actually not the actual surgery, if you will. Neither the surgeon, the donor, or the recipient. It's the time in between.
Only young people can get transplant.
Not at all. We've taken away the upper age limit. There's no upper age limit as such. It's your physiological age which is important.
Today I have with me Dr. Kumud Kumar Dhital, who is an internationally acclaimed cardiothoracic and transplant surgeon with over 25 years of experience. He is also the head of heart and lung transplant program at the Apollo Hospitals, Chennai. Doctor, thank you so much for talking to us. Doctor, can you tell us about the awareness programs regarding heart and lung transplant in India?
I mean, the heart transplant program in India is actually very old. You know, I think it was the fourth heart transplant ever done was done in India. But over the years, and certainly in the last 5 years or so, it has grown significantly, but really only in about 2 or 3 centers. And we are way underserving the need of the nation. So as globally, transplants, if you look at it, is probably serving, even in the best places, 1/10 of the requirement. And in India, it's way less. So how do we increase this? The donation, regulatory authorities controlling donations are becoming increasingly better, I would say. But not all states have it to the same extent. And there are lots of reasons. There is a misunderstanding or a low level of understanding about thoracic transplants, heart and lung transplants, the benefit thereof. Because we don't have enough recipient survivors in the communities where donations are occurring, and that is your best ambassador to let people be aware that the therapy has value and is able to return people who were very sick that you noticed, who are now back leading a normal life, often going back to work, being with their families instead of being a burden. And I think one of the misunderstandings has been the lack of appreciation of teamwork. And heart and lung transplantation, I would argue even the other transplants, but this particularly so because of the need for very high-end intensive care experience and expertise, requires a multidisciplinary team like an orchestra, that all the instruments play the same tune, right, under a conductor. And that's not happening to the extent that we would wish.
And do we have enough awareness programs for this?
Listen, there are lots of awareness programs, and not only are individual hospitals like Apollo doing their own programs locally and nationally across its network, it being such a large, vast network in India with over 10,000 beds, but there are institutions like the Mohan Foundation, which again is started off here in Tamil Nadu, doing extensive national work in trying to inform the public about the value of organ donation. So there are many things we need to do, but you're right. One is clearly one of informing not just the public, but also our own professional colleagues who often do not realize actually the value of the transplant in terms of survivorship of patients if they're doing well into the long term.
So you spoke about, the value of these transplants. What is that one story that stuck with you?
2014, after many years of research and doing these transplants in animals and so on, in Sydney, where I was then, we did, and I performed the first series of DCD heart transplants, and that is now 11 years ago, more than 11 years ago, and some of those patients, the first patient's still alive, doing well. That is enormous value. And the other one is to see young patients who go back to a normal quality of life, and as I said earlier to you, are contributing to their family welfare and to that of the society. There can't be anything greater than that. And all through just the gift, a simple free gift of organs that you don't need when you pass away from here to somewhere else.
I've been talking to a lot of people. The one thing that everyone kept asking me is that when a patient comes to you, how do you, decide that this patient requires a heart or a lung transplant? Yeah, what is the process that is involved?
That is fairly straightforward. We know, and most doctors can differentiate absolutely well, that this is either a heart only or a lung or a combined disease process, right? But it's recognizing the time when patients should be referred to a more specialist center and more experienced care. And that's one of the difficulties I find in India, is that whilst certainly in the West, there has been now for over maybe a couple of decades now an understanding that advanced heart and lung failure, advanced organ failure, are niches in their own right with enormous populations to serve. I feel that here perhaps a lot of physicians, they're jack of all trades, many of them, and feel that this is something they're quite good at handling. But it's not converting into the right time of referral of these patients. So we're seeing patients being referred very late in their disease process, which makes several things very difficult. One is that we as a transplant team, if we feel that transplantation is appropriate, need time to build trust with the patient, because essentially they're relying on us. And unfortunately, transplantation is also an expensive therapy. So to be told when you're arriving this late that yes, you need a transplant and it's going to cost you this much and this is how your quality of life will change, but it also means you have to do certain disciplined things to maintain your chance of survivorship into the long term, it's just too much of a shock to that individual and their family. We have not had that dialogue slowly over months to say, listen, you're a bit early, let's see you in 3 months, let's see you in 6 months, your doctor's doing the right thing, and creating this sort of tripod of trusted relationship.
So what are the signs or the conditions that is something which is important, that cannot be ignored?
Well, this is where the difficulty lies, because the signs and symptoms early on could be masking for so many other diseases of the heart and lungs, right? And it's only as you progress, the amount of medication you're requiring, it typically starts with shortness of breath, right? Or chest pain, but typically lethargy, difficulty exercising, doing your daily routine activities, which for those that are plus 55, 60, are beginning to put it down to old age. And it really isn't, because that's...
I've grown old.
Yeah, that's such a common thing I hear. A 60-year-old who comes, but doc, I'm old now, 60. And... but that's so young, If you say, well, what were you doing 2 years ago, 5 years ago? And you notice it was completely different, chalk and cheese. And so people have different expectations depending on which country you're in at a certain age about their health, about their longevity, and also what the family thinks they should be contributing or not. And that's a fascinating mix.
And you talked about preparing a patient,
Yes.
having that dialogue and
Yeah.
discussion. Before such a major surgery, what exactly is the procedure that is followed?
There are two aspects to it. One is that we as a team need to inform the patient about what's happening. And one of the first questions I often get is, doctor, why should I have a lung transplant if I'm only going to survive 1 year? And I typically say, if you were only going to survive 1 year, I would not be offering you this therapy, because that would be foolish, because it costs the time to recover, so on, doesn't make any sense. And the reason why transplantation cannot be determined just by me being the head of the program is that everybody has a veto. We put not only this head-to-toe workup that's done, looking at every organ, literally everything, to discover if there's any hidden disease, particularly cancer or other diseases, that might put at risk the life of this patient if he was to have a transplant. But don't forget, we have two responsibilities. We have a responsibility to the recipient to keep them as alive as long as possible. But we also have, as a transplanting team, a responsibility for the donor, and to try and make sure that the match is such that the donated organ also survives as long as possible.
What is the most critical moment during a transplant surgery?
The most critical moment for a heart and lung transplant is actually not the actual surgery, if you will, and neither the surgeon, the donor, or the recipient. It's the time in between. So the ischemic time, the time when blood has stopped flowing into the organs in the donor to when the blood starts flowing again in the recipient. It's a very critical time, and different organs have different resilience to that ischemic time. Ischemia meaning no blood flow, right? So no oxygen or blood flowing. And kidneys can survive longer than livers, and lungs are not bad. They can, survive several. Heart, ideally, the heart should be plumbed in. That time should be less than 4 hours. But there are exceptions. A young donor into a good recipient, you can extend that a lot bit longer. So that is critical. And then there is a whole, for heart and lung, the conduct of surgery is clearly important. But it's the post-operative care in the intensive care unit, because the heart and lung patients can succumb within minutes if something isn't, you're not vigilant. Whilst it's not the same time-wise in terms of literally minutes for other organs. And so that vigilance requires an expertise to understand and appreciate a good trend, good beneficial trend, and a downtrend, which is more critical. You want to treat the trend and correct the trend and not an event. By the time an event occurs, you're really having to dig yourself out of a hole.
So can you share an example of where a patient has overcome any kind of difficulty after post-surgery or a complication?
Absolutely. And it's not always plain sailing. Not through lack of effort or sometimes things are just unlucky. So patients for lungs, for example, they might get an infection, and it might be a fungal infection. That will put them on the ventilator for longer. They'll be in the ICU for longer. And the longer you are bedbound, the longer that rehabilitation process is for them to be on their own feet, to be going home. And hearts, some hearts that may not just fly off, and you can't wean them from the heart-lung machine, and you have to support them for a while on artificial circulation. So all these are complications. They're accepted complications. The later you are referred, the more likely you are to run into these problems and complications.
How does life change after a transplant?
Yeah. For the majority, it really is transformative in that they do return to a normal quality of life, albeit with a bag full of medicines. They've got their own medicine cabinet, and the vigilance of just hygiene that a lot of us learned over COVID. So hygiene, contact, staying away from dust and pollution, being careful of children with coughs and colds, trying to avoid pets and pigeons, and living in a house that hopefully has got, electricity, running water. You don't have damp and mold. All these things that added risk whilst you are immunosuppressed after transplant. Your defenses are down. So you need to have that extra vigilant and more protective environment to do well to survive into the medium and long term.
So this lifestyle change is forever?
Correct, for life.
What has been your experience in dealing with these patients, your patients, transplant patients? Were they able to do the same things that they used to do earlier?
Yeah, absolutely. So majority go back, and some, depending on the age. So the young guys, majority go back to work. The older ones who retired and so on go back to routine quality of life. And the others in between, some who choose not to go back to work. They found a new lease of life. They want to spend time with their families and so on. And that's not to say there aren't certain individuals who benefit, but not as well. They may not be as great as they used to be, but at least they're they're independent and able to be in the family, but they might not be, running around.
There is also a lot of misinformation about transplants particularly. So here there are a couple of things which Nitin, who is the producer of the show, came up with, saying you have to be on your deathbed before you can get a transplant. Is that true?
Well, yes and no. I mean, when you put it that way, the point is, as I go back to saying, is the patients refer too late. So they're already being, let me take lungs, for instance. Patients often being referred when they can no longer do a 6-minute walk test. They cannot do a lung function test, which in many centers would actually stop them being candidates for lung transplantation. So we're seeing really the very sick end of the cohort. And that shouldn't be. It should be a protective strategy to get them back to life earlier on in life and quality of life by virtue of a interactive, trust-growing relationship, and then the therapy being given to them in a timely fashion. Because patients are put on a wait list, right? It's not something that comes off a shelf, sadly. Unfortunately, and the sad part about all of this, actually, is that somebody's got to die. It's a very crude science and crude therapy that we have to rely on somebody else's death in order to save someone else.
Misinformation is, once you get a transplant, cured for life. Is that true?
Oh, well, it's true because, again, it's one of those things that need a bit of definition. So transplant is good for your entire life, but your life is whatever you have in front of you. If you're going to die in 2 weeks' time, it's still giving you a life. The question here is really what you're getting at is life is normal life, right? So that needs a little bit of explanation. So we want patients to return not only to, there are two things why we're doing this. We're trying to get rid of patients' symptoms, which is causing them harm, causing them discomfort, and we want them to return to as near normal a lifespan as possible.
The next one is a donor's personality or memories can be transferred with the organ. This is a very common thing that's there on the internet. So
It is, and you can take it several ways. I mean, I've never come across it. Right, I've never come across a patient who's either described changing their food habit or their music interest or anything else. But there appears to be plenty out there. So with a different hat on now, what I'm trying to say is we forget that there are nerve cells. There are more nerve cells in your gut than there are in your brain almost. And there are nerve cells also in your heart. So when you say, I feel it in my gut and I feel it in my heart, it may all be possible. And now there's a whole mixture of different theories of where memory is laid in cellular memory. We don't know. So I mean, there are enough anecdotes out there to think, maybe there's something there, but I personally, nor my colleagues, have come across it in any meaningful way.
Okay, so there's another myth that is only young people can get transplant.
Not at all. Absolutely not at all. In fact, the upper age limit now, for heart and lungs at least, and in fact livers and kidneys you can do even older, we've taken away the upper age limit because... Absolutely. There's no upper age limit as such. It's your physiological age which is important. You have a 70-year-old. I mean, the oldest heart transplant I've done is over 74. Same with lungs, 75. It depends on if the 75-year-old is looking, functioning like a 65-year-old. That's the age they're really at in respect of their transplantation. Correct. And how they will do post-operatively and how will they recover and end up going back. So it's targeted at your functional physiological age and not so much your chronological age.
So the next question is, if you are an organ donor, doctors won't try as hard to save you.
Won't? No, this is a complete, very much of a misunderstanding. It's not that if you're a donor, well, you're not a donor until you are brain dead or circulatory dead. Nobody's considering you to be anything else. I mean, all colleagues I know are working tirelessly to keep everybody alive as much as possible.
It differs from one hospital to another hospital, or one patient to another patient, or from government to private. Maybe doctors have a different kind of opinion on that.
Well, I think we should note that, a lot of the donations are coming out of government hospitals. In fact, they could probably provide even more, but they're so jam-packed, they're so crowded, they're so already overworked, and they have limited resources and they have limited beds. And do you continue to care for somebody who's brain dead, or do you, in the hope of them becoming a good donor, or do you try and save somebody who's just come in, who can be saved and returned to life? These are very difficult questions, and you have to be really there to understand what the doctors are facing, particularly in the emergency department, in the critical care scenario, how the managers are coping with this infrastructural and their burden of disease that's bringing patients. So I'm not sure that really is influenced. It's possible when you hear the newsprint that there clearly is, every now and then something will crop up some scandal about transplant and so on. So I'm not saying that the entire ecosystem of transplants, I'm extending this out of the heart and lung because we necessarily have to rely on deceased organs. But for livers and kidneys, you hear these things in the news that crop up, and so you have to question, and hopefully our leaders out there who are administering our societies and so on can come up with better solutions.
Thank you so much for talking to us and explaining to our viewers about certain complicated things, but at the same time keeping it very simple. Thank you, sir.
Thank you for having me. Thank you so much.